Good evening, everyone. On behalf of IAP Kozhikode and IAP Kerala, first of all, a warm welcome to everyone who has come and joined for the one of the vibrant series of IAP Kozhikode, that is Meet the Doyens, Beyond Horizon Meet the Doyens. So we are having a season 5 today, and it's a privilege to have Dr. Balasubramanian sir, HOD Department of Pediatrics, Kanji Kamakoti, for starting the first Doyens series of this year. We welcome you to the meeting, sir. I also welcome our President of IAP Kerala, Dr. Vijay Kumar sir, for the meeting. Welcome, sir. And I also welcome Dr. C.K. Shashidharan sir, Senior Consultant Pediatrician and former Head HOD Department of Pediatrics, Government Medical College Kozhikode, who will be the moderator for the session. Welcome, sir. And our President of IAP Kozhikode, Dr. Mohandas sir, and all the senior pediatricians who has joined the meeting. I welcome each and everyone. I now invite Dr. Vijay Kumar sir, President IAP Kerala, for the presentation.
Thank you, Dr. Ajay. Respected President of IAP Calicut, Dr. Mohandas, Secretary Dr. Ajay, and State Secretary Dr. Johnny Sebastian, my best friend and the backbone of all IAP activities. Respected Professor C.K. Shashidharan sir, my beloved teacher and guide and mentor. All the senior faculty members, senior members like Surendran sir, Parvati madam, and all my seniors and my dear friends. An esteemed speaker of this program, the most respected teacher, Balasubramanian sir. We are now starting the season 5 of the much awaited webinar series of IAP Calicut, Beyond the Horizons and Meet the Doyens. This program was a grand success in the last 2 years and hope that this will provide an academic platform to all the pediatricians of Kerala this year also. We are lucky to have Dr. Balasubramanian sir for this year's inaugural program. I wish the program all success. Jai Hind and Jai IAP. Thank you.
Thank you, sir. Now I invite Dr. C.K. Shashidharan sir, Senior Consultant Pediatrician, Baby Memorial Hospital, sir, to moderate the session as well as to introduce the speaker, Subramanian sir.
My dear friends, the IAP President Dr. Vijay Kumar, Dr. Johnny Sebastian, Dr. Ajit, and dear Dr. Parvati, Dr. Surendran, and my dear friends. It's a rare privilege bestowed on me to introduce a great speaker and a medical director of Child Trust Hospital, Madras, headed by Kanchi Kamakoti Freedom. And he has been a prolific writer. I still remember the first concise article on MS came from him only. And he has been a very ardent clinician, very good research worker. And we know that in Dipen Bay, Kanchi Kamakoti Freedom, that is Child Trust Hospital, is rated as #1. And students all over the country give their first option to Child Trust Hospital. That shows how he has been nurtured and how he has been heading the department. It's fortunate for that institution that he shifted from Ramachandra years back. And we have met him several times as an inspector by National Board. And we met him sometime back in Calicut. He came for accreditation of the National Board for Pediatrics, and we have pleasant memories about him. And it's my pleasant duty to present to you Professor Balasubramanian for the talk. And I don't want to interfere or make any comments on the topic which he is going to deliver. It is his pet topic, and he's on it for several years. Thank you.
Can I start, Ajay? Or?
Yes, sir. You can start sharing the screen, sir.
Okay, one minute. Is my screen visible and my audio is okay?
Visible, sir. Visible.
Okay, okay. Good evening, friends of the Kerala IAP and the Kozhikode IAP. I'm extremely happy to see through the web some good friends from Kerala. And I'm extremely thankful to Dr. Mohandas Nair, the president of the Kozhikode chapter, for inviting me, and my dear friend, Dr. Vijay Kumar, Dr. Mohammed, and of course, Dr. Shashidharan, Ajay, and the senior pediatric professor, Dr. Parvati. I'm very happy to do this session today for the Kozhikode IAP, which is a very enlightened chapter. I chose a specific topic close to my heart: pediatric infectious diseases, challenges, and changes. The next 45 minutes, I'm going to discuss about the challenges that we have faced and what has changed over the last 3 or 4 decades. I'm going to share my personal experience in various areas, which includes vaccination and changing scenario, sharing of some personal data from my work and publications on TB, dengue, entry care, etc. I will first finish with my new experience with COVID-19. I don't think any talk on infectious disease will be complete without COVID-19. I will discuss the impact of technology on diagnosis and treatment and the importance of antibiotic stewardship and the future of PID in India. Are pediatric infectious diseases a challenge to treat at all? Are children dying still of infections? I still remember before the onset of the COVID pandemic, Dr. Soumya Swaminathan, the present WHO chief, came to inaugurate a virology lab in our institution. And during the inaugural address, she said, future is going to be all lifestyle diseases, infectious diseases will not be a problem. And even such a senior scientist was proved wrong with the advent of COVID-19. Again, PID, infectious disease, again occupying the headlines and the WhatsApp everywhere today in the world. And children are still dying of infections. If you look at this data from Lancet Global Health, you find the children continue to die due to diseases such as pneumonia, diarrhea, and meningitis, particularly in poor countries and developing countries like India. And what do they die of? Majority of them die due to infections. And unlike the West, where babies die due to defects and prematurity rather than due to infections, in India, infections continue to kill children, particularly below the age of 5 years. Having said this, is the ball game changing in PID? Is something new happening? Yes, a lot of things are happening. What is happening is that we are understanding infectious diseases better. We are diagnosing better. We are diagnosing faster. We are treating better. We are vaccinating for various diseases. Our hygiene level has improved. We have got potent antibiotics and we have got evidence-based medicine. So in the 21st century, things are definitely changing for the better in infectious diseases. With this brief introduction, I will take up my experience with regard to vaccinology. Fortunately or unfortunately, most of my clinical trials I have carried out, about 30 in number so far. 12 of them have been in vaccinology, some vaccine trial or some surveillance data related to vaccine. What has happened to vaccinology in India? We have eradicated polio and smallpox. Measles is very much on the wane. Congenital rubella, we are going to see the end with the MR campaign. And DPT is very much controlled. And we find COVID vaccines are saving lives. You know, most people who die are not people who receive vaccination. However, The anti-vaccine lobby is very active worldwide. Every day I see one child not being given vaccine because of some irrational fear. And still myths about MMR vaccine causing autism still exist. And these are all dangers of decline in herd immunity. So which is going to cause a problem. There is going to be resurgence of pertussis, resurgence of measles, if we allow the anti-vaccine lobby to overpower us. But what is happening with regard to vaccinology in India is that there is a dichotomy between the ACVIP and the UPI schedule. In fact, in Kerala, you know, when we gave the recommendations, and as a chairperson of the ACVIP, there are a lot of eyebrows raised when we talked about IPV, when we talked about influenza, and the UPI schedule is different. But I look forward to the day when India will have only one schedule, not ACVIP different and not UPI different, one schedule for the India. The government will give all the vaccines which the ACVIP recommends. Because there is a huge shortage of vaccines. We went through DPT not being available, IPV not being available, and the switch to IPV has been slow. However, we all should know that the vaccine-associated paralysis and vaccine-derived paralytic poliomyelitis, the threat is real. In fact, today in India, the risk of poliomyelitis due to vaccine is greater than due to a natural transmission. In fact, as chairperson of the ACVIP, with a very good team, we came out with the guidebook on immunization, and we made some changes which are revolutionary. What are the changes? Before I talk about the changes, let me share one of my earliest publications related to poliomyelitis. You must be wondering, how is this related to poliomyelitis? Actually, while I was a young registrar, I came across a few children who had acute watery diarrhea, severe dehydration, and with potassium levels being very low, 2.1. And all of them, as you see in the picture, had one peculiar finding, phantom hernia. What is this phantom hernia? It's actually a pseudo hernia, weakness of the abdominal wall, causing bulging when the child is crying. It's a peculiar term. And all the three children we encountered had severe hypokalemia with ECG changes. And you see here in the X-ray the bulge, and it occurred only in one side. We could not explain why. Of course, we could not do polio studies. All these children were vaccinated, and we published it as an unusual manifestation of hypokalemia. The reviewers refused to initially accept, saying this could still be polio. Now, after that, we have seen several cases of hypokalemia presenting with phantom hernia. So phantom hernia, which used to be considered as a sign of asymmetric paralysis, it occurs only on one side, as a unique sign of poliomyelitis, everybody started accepting it as an unusual manifestation of hypokalemia. The next area where I had the opportunity to take part in a study was the Rotavirus Gastroenteritis. We did a study way back in 2003-04, and we concluded that rotavirus was the commonest cause of acute watery diarrhea in outpatient clinics through this study. And later, there have been always controversies about rotavirus vaccine. There was a threat. There was a letter from South Africa in one of the esteemed journals saying that if you introduce rotavirus vaccine in developing countries and underdeveloped countries, we will lose more children due to intussusception without treatment than due to rotaviral diarrhea and dehydration. A lot of criticism about rotaviral vaccine. WHO was also worried. So the CMC Vellore, led by Dr. Gangadin Gang, an extremely very enlightened epidemiologist, she, with the Bill Gates Foundation and support from the US, she carried out a rotavirus surveillance study, which was published in New England Journal. I'm proud to be part of this surveillance study, to find my name in New England Journal. And what did we show? The Indian rotavirus vaccine from the Bharat Biotech was not associated with intussusception. This is a surveillance study which went on for 3 years, and we conclusively proved the risk of intussusception is extremely negligible. Another study of intussusception was carried out again under the guidance of Dr. Gagandeep Gang, where we had also reported there had been no increase in intussusception hospitalization. I was happy to be part of this multicentric study. Polio has been eradicated, and India has been approved to be a country which is polio-free. Then, in the ACVAP recommendation during my chairpersonship in 2018-19, we introduced several new changes. The most important was the introduction of IPV combination with the DPT, hepatitis B, and Hib. And we also said that you can use either acellular or whole cell vaccine, much in contradiction to the earlier recommendation. We also introduced the influenza vaccine below 5 years, which we thought is definitely required to bring down the morbidity of secondary infections like otitis media and morbidity due to influenza below the age of 5 years. Then the controversy of OPV contamination emerged with a few cases being reported from Maharashtra. There is a huge debate, and I was to take part in a TV debate where the anchor pinned all of us saying that the government is not doing enough for surveillance and we should introduce IPV very fast. I personally believe we should see the end of OPV administration in India. In fact, in my clinic, I do not have stocks of OPV. I don't give at all OPV. I give only IPV. I think in a civilized society, we should not be giving OPV anymore. I think in the next few years, the ACVAP also will recommend stopping OPV, even zero OPV. But the flu vaccine recommendation was a game changer. And we strongly said from 6 months of age up to 5 years, we can give quadrivalent or trivalent. Now quadrivalent is very much available, and single dose of 0.5 is now approved. This has become the order of the day. And this is the schedule we presented in 2018-19. And we again changed the previous recommendation of 2 doses of typhoid to 1 dose because there is no data to support the use of second dose. And these are the changes we could achieve through the ACVAP. Next area where I had a lot of interest right from the beginning. As a student, I used to be taught about primary complex. In the Institute of Child Health, we used to be taught about the 20 different findings of the X-ray in primary complex. We have moved from primary complex then to National Tuberculosis Elimination Program and RNTCP. Now we are talking about National Tuberculosis Elimination. The government of India wants to eliminate tuberculosis by 2025. I hope this will occur just like HIV elimination. I'm going to share a few interesting cases I saw with regard to TB. TB is one great mimicker. This was a 2-month-old infant who was well nourished, who was growing well, who had fever, respiratory distress, and hepatomegaly. And as you see here, huge hepatomegaly, bronchopneumonic changes, a mild cardiomegaly, mild anemia. Cultures are negative. But then the liver was so firm and the X-ray showed nodular opacities in both sides. Something told me this could be tuberculosis. The mother was quite healthy, as you see in the picture. She was not malnourished. She denied any history of tuberculosis. We took an X-ray for the mother also. X-ray was normal. But still, we did a gastric juice for AFB. And my microbiologist called me the next morning, sir, the entire field is full of zeal-9 positive AFB. And we grew AFB in the culture. And then we investigated the mother. Many were not accepting this is not congenital tuberculosis. We investigated the mother. We did an enterometrial biopsy and culture. We proved tuberculosis. And thanks to National Institute of Research in Tuberculosis, the tuberculosis strain in the mother and baby were genotypically same. So we published this as congenital tuberculosis. One of the peculiar things in tuberculosis is that in spite of large numbers of tuberculosis in children and adults, congenital tuberculosis is very rare. There are only something like 100 cases reported in literature. It is because maternal tuberculosis, endometrial tuberculosis leads to infertility. They don't give birth to children. That's one of the reasons tuberculosis, congenital tuberculosis, is less common than other forms of tuberculosis. The other unusual manifestation of tuberculosis I happened to see were a group of children. I don't know how it came in clusters. Same month, 3 children, all in the age group of around 9 months to 1.5 years. They all came with gluteal abscesses and they didn't respond to antibiotic. And all the 3 were drained outside by surgeon. As you see in the picture, these lesions never subsided. They continued to emit some caseous material. We are wondering, why not this be tuberculosis? And we did an AFB stain. We did a culture. It was human mycobacterial tuberculosis by culture. This is very, very unusual. And all of them gave a history of intramuscular injection at the site. And one of them had a measles injection at the buttock wrongly. We could not prove how this tuberculosis and the vaccine could, or the injection could be correlated. And this is the first report of tuberculosis gluteal abscess in literature. And all these children are well known. This is another interesting case, something related to tuberculosis. This infant, unfortunately, who died, this infant presented at 2 months of age with severe seborrheic dermatitis and fever for 1 month. Look at the severe seborrhea. The baby had hepatosplenomegaly. The X-ray showed bronchopneumonia changes, and the baby had pancytopenia, high ferritin levels. And then we went on to investigate for hemophagocytosis. And we did a bone marrow, it showed hemophagocytosis. We didn't stop with that, we did a gastric juice for AFB, teaming with AFB. Culture-proven tuberculosis causing hemophagocytosis. This again is the first case of TB-associated hemophagocytosis in an infant in world literature. We did a liver biopsy, of course, post-mortem. After the baby died, we gave etoposide, we gave immunoglobulin, we gave steroid, baby died, we also gave ATT. We could not save the child. This is the first case of hemophagocytosis due to tuberculosis in an infant in world literature. This is another child, 10-month-old, who presented this with fever for 15 days and had encephalopathy, seizures. CT brain and chest X-ray were done. CT brain showed a hydrocephalus. The mother looked malnourished. We did a lumbar puncture. The CSF is absolutely normal. Glucose, protein, normal, no cells. But then we were highly suspicious. We took the X-ray of the mother. Look at the X-ray of the mother. There is a cavity. She was sputum positive. And we, of course, proved we did do an MRI and then did the culture of the CSF, which grew AFB. What we observed was that the CSF is completely normal. When we went to look for the evidence in the literature, Dr. Tilottamal from Institute of Child Health, 10 years before this, had published her series of tuberculosis meningitis, where 15% of cases of tuberculosis meningitis may not have a cellular response or a protein elevation. So a normal CSF does not rule out tuberculosis meningitis. That is what we observed. So tuberculosis can mimic any disease. This is another interesting boy who's still alive and doing well, 9-year-old boy, who came with mandible swelling, osteomyelitis. He had a long story. He had BCG adenitis. He was given INH. He had cough and cold, which was treated as tuberculosis primary complex in second year, recovered. He had multifocal tuberculosis osteomyelitis in the hip bone and also the ilium at 6 years of age. And then we did a bone biopsy. It grew Mycobacterium species resistant to INH. And when we did the bone scan, he had multifocal lesions all over. And everything was growing AFB. We are wondering why this fellow is getting recurrent tuberculosis. Tuberculosis in infancy, later, well-nourished boy. Then all the immunological investigation we could do were negative. Flow cytometry, immunoglobulin assay, etc. I contacted Dr. Soumya Samanathan and asked her opinion. She said this could be gamma interferon. This is way back 15 years back. And she told us, Bala, you investigate for gamma interferon deficiency. And then he did not respond. We ruled out multi-drug resistant tuberculosis. Compliance to treatment is okay. Then we sent the sample to France, where there is a researcher called Casanova, who is an authority on gamma interferon defect. And she responded by doing gene assay for this, and it turned out to be a gamma interferon receptor defect. This boy is doing well. This receptor defect will not respond to even interferon infusions. He's on azithromycin prophylaxis. He's doing very well and alive without recurrence of tuberculosis. What I'm trying to say is that from the days of diagnosis of PC with an X-ray, we have moved forward to diagnosis microbiological confirmation of tuberculosis with gene expert and MGIT culture and new methods of culture. And we have also moved to new methods of eradication by starting preventive therapy. In fact, the recent Government of India guidelines say that you should start preventive therapy even for adults when there is a contact. So we are starting to give INH to those who are Manto positive, asymptomatic at whatever age you diagnose, or those adults with contact with tuberculosis. So we hope to see the end game of tuberculosis by at least 2035. Next is an area of interest for me, because the area of interest to every pediatrician. I'm sure all of you would agree, dengue is a disease which has emerged as a huge threat. Unfortunately, it is not receiving as much attention as COVID is receiving, because it is affecting more children in developing countries and poor countries. And in 2001, we described the dengue epidemic in Chennai, where for the first time we reported 20% of cases were below 1 year of age. That was the highest percentage reported in literature from India at that point of time. Now, everybody says, even in infants, it's around 15%, 10%. This is the highest reported in Indian literature. This we reported in a prestigious journal. And then later, we learned a lot about dengue. What did we learn? We moved from the definition of dengue hemorrhagic fever to dengue and dengue with warning signs and severe dengue. This has rationalized the management. And we wrote a review article in Archives, and we wrote way back in 2012 that the most important task for the scientists is to identify the small group of children who are likely to develop severe dengue early, and then focus efforts on preventive treatment, possibly the immune modulation and or antivirals. Unfortunately, we have not had a good vaccine. We have not still discovered a good antiviral. And we are debating the use of immunoglobulin. We are debating the use of steroid. We don't know when to give it. I am sure in the next 5 years, we will come out with good therapeutic options for dengue. And we reported that there are very good predictors of spontaneous bleeding, which includes a biphasic pattern of fever, hemoconcentration, platelet count less than 50,000, and markedly elevated ALT. These are the factors which increase the risk of bleeding in dengue. That's what we reported. Another important work we had done, we tried to look at the criteria to diagnose plasma leakage in dengue hemorrhagic fever. And we found that the PCV may not be reliable. And ultrasound is extremely useful. That is what we reported. In fact, clinical findings of the presence of ascites or pleural effusion or ultrasonic finding of pleural effusion or ascites predicts the occurrence of shock much more accurately than monitoring PCV. That is what we reported in 2006. Then we reported for the first time in India a series of cases of hemophagocytic lymphohistiocytosis in which 4 children had dengue. So this is the first report of dengue-associated HLH Now every center is reporting, and this is a big problem in treating and diagnosing. Now we are doing more of ferritin estimation in dengue because of this assessment. Another important area of interest for my research has been enteric fever, where I will share the personal experience. If you see the roadmap of resistance in typhoid, way back when I was an MBBS student, we used to give chloramphenicol and the fever used to come down in 3 days. Then somewhere in the 1990s, when I was the registrar, chloramphenicol resistance became a big problem. And 1991-92, ciproflox resistance emerged. And now in 2010, multi-drug resistance emerged, including ceftriaxone. And now we are seeing ceftriaxone outbreak in Pakistan. So this map is changing, resistance is changing. Earlier, when I was the registrar, we reported one of the largest series of multi-drug resistance in typhoid from Chennai. What did we show? Nearly 3/4 of the Salmonella isolated in 1991 were resistant. That's what we observed. Again, the pendulum swung back. Later in 2008, we analyzed the sensitivity, and the sensitivity to chloramphenicol has come back, sensitivity to cotrimoxazole has come back. So much so now we are considering cotrimoxazole use for mild typhoid as OP. This is what has been happening. The pendulum is swinging back towards chloramphenicol and cotrimoxazole and amoxicillin. But then came a problem. In our own institution, in many units, 2 drugs were used for enteric fever, and they were saying, why take a chance? Give both ceftriaxone and quinolone, or ceftriaxone and azithromycin, or ceftriaxone and chloramphenicol. Why not you use? After all, it's a gram-negative organism. Using 2 antibiotics will shorten the duration. But then we analyzed and found in different groups, those given single drug were compared with those given multi-drug. And as you see here, the number of days of fever and illness did not differ. And you see the mean duration of deference of fever. The single drug group, it was 5.24, and the multi-drug group, it was 4.32. So we wrote, we should not be using multi-drug therapy in enteric fever. Like monogamy, it's better to use a single drug. Now we use only ceftriaxone or azithromycin and not both. Other area which had aroused our interest was an area peculiar to typhoid. Typhoid can present with jaundice. That's what literature says. And once there is jaundice, you always have a confusion. Is it viral hepatitis or typhoid hepatitis? At that point of time, we compared children with hepatitis A and children with typhoid fever and analyzed the LDH-ALT ratio or ALT-LDH ratio. This is very interesting. Typhoid fever is an ischemic hepatitis where LDH goes up much more than ALT. Viral hepatitis is a non-ischemic hepatitis where the ALT goes up more than LDH. So what we found was that if you have a child with jaundice in whom there is fever, you don't know whether it is viral hepatitis or typhoid, you can do LDH estimation and compare it with LDH. If the ratio of ALT to LDH is less than typhoid, it is likely to be typhoid. If it's less than 9, it is likely to indicate it is typhoid. That means LDH goes up much more in typhoid than in viral hepatitis. If the ALT-LDH ratio is more than 9, it could give a clue it is acute viral hepatitis A or E. This is another interesting case. We all think of typhoid only when there is fever for 3 to 5 days. But typhoid is like TB, can present any way it likes. This is a young infant who had only fever and bout of crying. 1 day fever, exactly 16 hours. Came with a bulging fountain like meningitis. CSF is normal, no other signs. Blood culture grew Salmonella typhi. We could report as the first case of pseudotumor cerebri in the international literature. So the message is You should think of typhoid, whether it is 1 day fever or 1 month fever or 1 year fever. That's what we reported. Another interesting finding we have found in our institution is that if you have a child who has very high fever, say 104, 105, whatever is the day you start treatment, it is going to take longer than a child who presents with only 101 and less than 102. So the higher the fever at the time of diagnosis and investigation, the more is going to be the number of days of fever. So that is not an indication for changing the antibiotic too frequently. But unfortunately, in a country like India, typhoid continues to occur. That is because the hygiene levels have not improved. And the need for typhoid vaccination is definitely there. Why? Because we pediatricians, once there is fever for 4 to 5 days, we always think of typhoid and start an antibiotic. And many of them are not typhoid. So for improving antibiotic usage and improving antibiotic stewardship, we need to promote typhoid conjugate vaccine and decrease the incidence of typhoid. The next area of interest for me has been over the last 2 decades, has been invasive pneumococcal disease. When we talked about pneumococcus 20 years back, people are laughing, where is pneumococcus in India? But then in India, there is inefficient diagnosis of IPD. Blood cultures are not done in a large number of cases. Antibiotics are given before cultures. There is no true data. There is lack of IPD surveillance. That's what we wrote in IJM. Then we asked ourselves a question, it is possible to prove pneumococcal pneumonia? The answer is yes. How did we prove? As part of a multicentric surveillance study, which was published in Lancet Infectious Diseases, where I was also part of the surveillance study, we gave the second largest number of cases of proven pneumococcal disease. We found that pneumonia is the commonest type of IPD. Meningitis does occur. And we found at that point, drug resistance was not a major problem. Then we are also part of a multicentric study to assess the immunogenicity and safety of 13-valent and 7-valent vaccine. Both the vaccine trials we took part, and it had good immunogenicity and safety. Now that's all history. PCV13 and or PCV10 is being used in the UPI. Coming to the stewardship work, I would share some personal experience. The most important reasons are the challenges. What are the challenges? There's an abuse of antibiotic everywhere. This has led to a lot of resistance, irrational use. Evidence is there, but everybody has his or her own office practice rules, and they don't follow the guidelines. An antibiotic pipeline, I'm afraid, is getting dry. The changes that are occurring, we are talking actively about antimicrobial stewardship. We are talking about rational therapy. Infection control has become the new mantra, that too with COVID pandemic onset. And we are identifying more viruses and using less antibiotics. This is one area we had worked on. We are seeing a rapid rise of ESBL UTI. We used to give ceftriaxone or cefotaxime for suspected UTI, pyelonephritis, before the cultures come. Now in our own institution, we have changed our policy. We use either meropenem, the child is very ill, or we use piperacillin tazobactam, because in our own institution, we reported that 40% of our UTI is due to ESBL. So that is going up. We have changed our policy. We use only amoxiclav or piperacillin tazobactam for inpatient or outpatient use of treatment for UTI. And the other observation we have made with regard to invasive pneumococcal disease has been a recent publication where we had identified 33 cases of invasive pneumococcal disease, in which you'll be shocked to know multi-drug resistance was to the tune of 45%. This is one of the reasons why in our own hospital, for anybody with suspected pneumococcal meningitis, we don't use ceftriaxone alone. We initially start with ceftriaxone and vancomycin, get the cultures done, get the sensitivity, then only stop vancomycin or continue vancomycin. The other area where we found there's a lot of scope for improvement is acute bacterial pharyngeal tonsillitis. As you see here, typical uvula, which is being red with the erythema, the exudate. This is typical bacterial. You can use the McKesson score and give antibiotics. But then we did a study on this rapid antigen testing, which is very cheap, which costs only 150 to 200 rupees. We do it in outpatient. I do it in my clinic. But unfortunately, it is not picked up across the country. Though in the USA, every pediatrician does it in the office practice, even during the COVID pandemic. The other area I have data which is interesting to share is immunodeficiency. We all know that there are 300 and odd, by now that number would have gone up, 300 genetically defined single gene PID. The outcome will be better if it is recognized early. In the New York City, they are doing neonatal screening for PID from the cord blood. I'm sure it will happen in India very soon. This is an interesting paper where we analyze our own data of primary immunodeficiency in our hospital. Very interesting finding, quite in contrast to what is observed in the West. In the West, most of the immunodeficiencies have been either hypogammaglobulinemia or severe combined deficiency. In our own series, most defects have been phagocyte function, most common being chronic granulomatous disease. That's the most common under-recognized immunodeficiency in India. They come with multiple abscesses, they come with osteomyelitis, they come with hepatosmegaly, recurrent antibiotic use. So this is the most common cause of primary immunodeficiency we observed. We also saw combined immunodeficiency and T-cell defects. We didn't see much of hypogammaglobulinemia. So from these, what we have learned is that you should have a high index of suspicion for primary immunodeficiency by asking ourselves why this child is having this infection, whether it is pneumococcal disease or meningococcal disease or Burkhardia. You should ask those questions, use the mnemonic of SPUR, severe, persistent, recurrent, and unusual, to pick up immunodeficiency early. I thought I would end my session, of course, sharing personal experience with COVID. I don't think any lecture on infectious diseases will be complete without a discussion on COVID. Over the last 2 years, in our own institution, this is what we have seen. What have we seen? We have seen, as inpatients, 329 children below 18 years of age who had COVID positivity. Most of them mildly symptomatic. We don't admit asymptomatic ones unless there is a high risk like immunodeficiency. We had so far, this data is up to January, we had so far treated 177 cases of MIS-C. Surprisingly, we have had only 2 deaths. And these 2 deaths were not MIS-C. MIS-C all have survived, all are doing very well. Only 2 children with COVID positivity died. And even in those 2 cases, COVID was only a bystander. One child had acute leukemia with tumor lysis syndrome who was COVID positive. The child probably died due to the leukemia rather than due to COVID. Another child had acute chronic renal failure who died due to renal failure in spite of dialysis and multiple bacterial infection rather than COVID. And as you see here, during this first wave, we didn't see many cases. We saw nearly 30 cases of COVID as inpatient. We saw around 10 patients of MIS-C. And during the second wave, we saw around 80. And the MIS-C figure climbed up to 30. And during the third wave, we are only seeing COVID and not much of MIS-C. We have seen only 3 MIS-Cs over the last 2 months. It's too early to predict what is going to happen to MIS-C. And I am happy to share with you that we reported the first case of MIS-C in India, for that matter in Asia. We treated this child with tocilizumab and immunoglobulin, and this child completely recovered. That was history. Now we don't treat them with tocilizumab. We give IVIG, and below 5 years and above 5 years, we use steroids. And we have used in anakinra in 3 cases successfully. Our MIS-C success rates has been 100%. And this is the These are the pictures of our first child with Missy, who had pneumonia like this with an X-ray showing consolidation. He was PCR positive, everything fitted into Kawasaki. But then we realized this is Missy and not Kawasaki. This boy is doing very well and is well now. And we analyzed the cytokine data, we analyzed the serology data of these children, and we found during the first and second wave, half the children who had PIMS-TS or Missy had seropositivity. Because now we are not relying on seropositivity at all. Seropositivity or negativity or PCR positivity or negativity, we go by the WHO criteria and diagnose Missy more rationally. And we analyzed the biomarkers, and we found the biomarkers are completely different. I'm not going to bore the audience with the figures, but we analyzed this and we published that the biomarker profile of IL-6, tumor TNF-alpha, IL-1A, so many other things were completely different in Missy, completely different in COVID-19 when compared to controls. And we published the largest series so far in India, first series, I would say, of Missy. That time we called it as PIMS-TS, which is what was being talked about in Europe. And what did we find? All these children recovered, zero mortality, and very few had cardiac complications. Even over the 177 cases, we have not seen many children with severe cardiac disease. Surprisingly, they are all doing very well. The other area where we just sat down with Professor Ramanan, the pediatric rheumatologist at University of Bristol. He has been all along telling, Bala, if a patient cannot afford IVIG, you need not give IVIG. Don't worry about IVIG. Don't waste money. You give steroid. So we wrote a letter in Lancet Rheumatology. What did we write? We compared the cost of IVIG with the cost of steroid. And we wrote, like the recovery trial of dexamethasone, a recovery trial of steroid versus immunoglobulin should give us more data. And we are waiting for the recovery data. Hopefully, the data will favor use of steroids over immunoglobulin so that our poor children recover faster with Missy. At the end of everything, I would say there are a lot of challenges for us. What are the challenges? Culture, which should be done in any child who's sick and who requires antibiotic. Unfortunately, cultures are not being done. The culture should change. The culture of culturing should change. Cost of new technology like PCR, 16S RNA, so many new platforms, unfortunately, is going to make us not perform it in rural centers and remote areas. And we should have high sensitivity data. We should stop having tests like BioFire in the respiratory system, which can come out with multiple positivity. We should have high sensitivity and high specificity. And we should have no confusion in interpreting the data. And what are the changes I anticipate? We are going to have point of care tests for every disease, right? We have rapid antigen tests. PCR, we must get the reports in 1 hour. 16S RNA, we must make it available for every deserving child. And we should have a balance between technological progress and clinical epidemiology. There's no point in trying to interpret all these lab data, which all comes in computerized form, which you and me, poor general pediatricians, may not be finding it easy to interpret. We should interpret all these reports along with the clinical data. And more importantly, we must use antibiotics sparingly. In fact, as a mission, me along with Dr. Paniraman, who's seen in this photo, we have conducted nearly 50 workshops today. We call it now APME, Appropriate Antimicrobial Prescribing Made Easy. And we conducted another program for the IMA for rational antibiotic therapy, and our mission continues. In our own hospital, what have we done? Any PG who comes to our institution, is being trained on antibiotic stewardship with a module which is called Antibiotic Prescribing Made Easy. We have an antibiotic guidebook which has been revised in 2021, and we hope to revise it this year. With this, what is going to be the future? The future is bright. There are going to be many challenges in the form of viruses like COVID-19. There are going to be many challenges in implementing technology, but the future is bright for pediatric infectious diseases. The game changers will be metagenomic next generation sequencing, where within half an hour, you will get a report of the pathogen, the sensitivity, everything, so that you can decide the antibiotic even within the golden hour. That is going to be reality in 10 or 20 years. What about the future of PID in India? It's a specialty which is not established. It only consists of somebody like me, self-trained. I'm not a completely trained pediatric infectious disease specialist. I'm ashamed to call myself an ID specialist. I'm a general pediatrician with interest in pediatric infectious disease. There is a need for training centers and personnel, and we are going to get more and more difficult infections like COVID and more technological advances to help us. Thank you very much. Please email your feedback, negative or positive, to my mail ID, sbsped@gmail.com. I have finished it exactly in 44 minutes and 30 seconds. Over to the organizers. Thank you very much.
Thank you, sir, for the wonderful presentation. CK, sir.
I think it has been an excellent evening for us. We listened to him, exciting talk, new areas, and how to manage infections, not only infections, especially the vaccinology, all aspects of child health care has been delineated in detail by Professor Balasubramanian. I would like all our the invitees and guests to respond. First, I must talk to Dr. Ajit to give his comments and remarks on this. Ajit, please.
Thank you, sir. Am I audible?
Yes, sir.
Yes, sir.
Because as CK sir has said, it's one of the best talk in this Doyens series. I'm really thankful to Balasubramanian sir for showing all the research work he has done and all the publications that he has posted here in this talk. And it's a lesson for all of us. We have to be both a researcher as well as a clinician. And wherever we are, even with whatever possible investigations or clinical material that we have, we can publish and do research. So it's a great eye-opener, sir. Thank you for your excellent talk. And one change which I have observed during this COVID season is that the antibiotic usage has come down drastically for this COVID season. Because most of the fevers now, which the pediatrician has recognized that it is viral fever and there is no need for antibiotics, especially in Kerala. I don't know about other places, but the use of antibiotics has drastically come down because of the guidelines as well as the change in prescription pattern which we have noticed. I think that's a good sign, and in the prescribing pattern of for pediatricians, I think. And we have another thing that I have noticed is that we are seeing unusual patterns of infections, unusual patterns of diseases during this COVID season. Maybe the number of IP admissions have come down, and we had more chance to look into deeply on every patient.
Yeah.
So maybe that's one of the reasons. Maybe but still, most of the cases which have been one reason which I would think is that many of the cases are really managed well in the periphery, which is a good thing because they cannot refer now, and only very complicated cases are coming to the medical colleges. So that might be the reason for us getting very complicated cases, very unusual cases, just like many of those case scenarios, case histories that you have presented in your lecture. So thank you, sir, for your eye-opening lecture on different aspects of infectious disease. Thank you very much.
Extremely valid points, Dr. Ajit. To respond to that, Kerala is a much disciplined state. So I'm not sure whatever that is happening in terms of reduction in antibiotics in Kerala is happening in any other part of this country. I can tell you from my own limited experience, every child whose mother calls me saying that my husband is positive or grandfather is positive, and the child is having mild fever, I counsel them over video WhatsApp. The next moment she will say, "Doctor, my husband has been given azithromycin and doxycycline. What about antibiotics for my child?" So I don't think whatever you say has been happening in other parts of the country and in adult medicine. I don't know about adult medicine in Kerala, but I can tell you, over the last 2 years, I would have stopped antibiotics over phone for at least 20 of my relatives, minimum 20 of my relatives who had called from different parts of the country, Bangalore, Mumbai, Delhi, and they go for COVID positivity and ivermectin, azithromycin, doxycycline, Favipiravir, a whole lot of medicines, including vitamin D sackets of 60,000 with a package given with a fee of 10,000 rupees. I don't think it has stopped happening even today. Because we generally, pediatricians are much more conservative than adult physicians when it comes to antibiotic. Whatever you're saying may hold good for Kerala. I'm not sure whether it is happening in other parts of the country. That is one. Second, coming to the unusually severe manifestations and unusual presentation. There may be two reasons. One is that during the COVID pandemic, what we found, parents did not bring in fact, we wrote it in one of the articles we wrote very first. We wrote an article, COVID. We wrote a perspective in Indian pediatrics, coronavirus infections, what we know and what we do not know, in which we wrote in the last paragraph that we expect COVID-19 to be a mild disease in children, but the indirect impact of COVID-19, like for example, a sick child not being brought to the hospital because of COVID, and because of poverty due to COVID, children not being brought to the right time, and ignorance, lack of immunization. And now you know the impact due to absence of schooling, psychosocial impact. That impact has been deadly in pediatrics, unlike in adult medicine, where the impact has been more on the physical health. The impact on the psychosocial health in pediatrics has been more than that of the physical health of children. In fact, many children whom I have not seen for 2 years over the COVID pandemic, the moment they enter, the first thing I find that the child is doubled. I'm sure it will be happening to all of you. That is one. Second, I've never seen so many psychological problems like I'm seeing over the last 3 months due to the internet and mobile use. That is another thing which is happening. These are all things which are happening. And regarding the unusual manifestations, in fact, even I've seen friends saying that this year dengue is presenting differently. we have analyzed our data. It is not different. It is almost very similar to what has been happening, right? The only thing that we find that even in dengue, if they do COVID positive, COVID PCR, that also comes as positive. But we have seen children with COVID positivity, with UTI, with RSV, with also your typhus, everything becoming positive. If you keep on testing, everything will be there, and we don't know which one is the real culprits.
Yes. Parvati can speak. Yeah.
Madam, you are muted. You are muted. Please unmute yourself, madam.
It was a real treat to go through your journey through years, personal experience and research experiences. And as you have rightly mentioned, I think the physicians, the adult physicians, write a lot of antibiotics, unlike we pediatricians. And most often they will, the patients who, when they phone, they will tell that the father or the grandfather had this antibiotic. Can my child also have that antibiotic? Especially azithromycin. Azithromycin is the most misused drug in COVID, I should say. What is your experience regarding that azithromycin misuse?
Yeah. Azithromycin, I call it Ganga Pani. For anybody who sneezes 4 times, because during the talk, if I sneeze 4 times, I'll be advised azithromycin.
Even lay people start using it
Yes.
once they become COVID positive. They especially during this Omicron, they are not going to the hospital, but they take azithromycin.
They take azithromycin. They'll come and the parents will come and say, "Doctor, I have sore throat. I'm taking azithromycin. What about my child?" I tell them, you stop your azithromycin, and your child also doesn't need azithromycin. It's a much abused drug.
And we are able to stop so many misuse if they phone us. Otherwise,
in fact, over when they consult me over WhatsApp video for their children, and they talk about their parents, I tell them, you fix up another appointment. I'll treat the child's father also, and I am able to treat.
Yes.
But I was even tempted to put a board in my clinic. I am going to start see adults with COVID. And after there's so much of fear. But somebody was joking, the most common symptom of COVID-19 is not fever, it is fear.
Yeah.
And that fear is being treated. That's all.
very true.
And in fact, in the Western data, they have only in 5% of COVID infections in adult. Pediatric data, there's hardly any. 5% of adult COVID, there had been proven bacterial infections. 5%. So the remaining 95% don't require. And even if 5% is there, at the most 20% of patients may require antibiotics. They're hospitalized, and if they have features of bacterial infection. Otherwise, routinely, nothing is going to help. Unfortunately, COVID has become an over-the-counter disease. Because of WhatsApp, the public know more about recent developments in COVID than physicians and pediatricians. They get WhatsApp messages. Even before a new drug comes, they'll know about antibody cocktail more than what we all know.
Mohandas.
Thank you, sir. So it was an excellent talk, your experience over the last half century also. And so this is what we expected also, asking for a talk from an experienced pediatrician. So thank you, sir, for being with us. Really excellent. Thank you.
I call upon Dr. Vijay Kumar for his remarks.
Sir,
Vijay
Kumar sir has gone for one more meeting, or a state meeting is there.
Okay, fine. So any comments from others? Any more comments, please?
Sir Balasubramanian sir, regarding your MISC follow-up data, does any of the follow-up cases had any severity of coronary dilatation or anything in your data?
Only 3 children have had residual aneurysms. Only 3 out of 177. They are analyzing the data. At least out of the 177, none had died, number 1. None had residual cardiac symptomatology, number 2. Number 3, 3 of them have definite aneurysm, which is persisting. We are following them up. They are on aspirin plus clopidogrel, and they are being followed up. We are yet to do cardiac MRI or CT angio for them. We plan to do probably at the end of 1 year. We are collecting. In fact, I'm happy to tell you we are part of International Kawasaki Disease Registry of the Johns Hopkins University, USA, and the Children's Hospital, Toronto. We have provided data of 50 cases of Kawasaki, 50 cases of MIS-C, 50 cases of COVID-19, and they are analyzing. We are also going to analyze and publish it. We are looking at the cardiac data. But unfortunately, practitioners, we don't find as much time as possible to analyze data. We have a lot of data. Everything is computerized. We have captured almost all the cases, the data of all the cases we had from the beginning. We have complete CRF for all of them. We have all the data. And, somebody, if I get a PhD student, a nice student, he can analyze and publish many papers, single center study, uniform data we have.
Geeta.
Yeah, thanks.
Yes.
Thank you.
Hello, Dr. Geeta.
Yeah, good evening.
I see you.
Thank you, Professor Balasubramanian. It was a wonderful talk. And thanks to Dr. Shashidharan, who is always with us throughout in all our programs. It was very stimulating to see the way you have not only worked with infectious disease, but made sure that everything is documented, published, so that over the years, you have this huge body of evidence, which you can proudly show and say that, yeah, this is what I have done. So that is something that we need to definitely learn from you. And I'm so happy that you have this entire gamut of a spectrum of infections on which you can speak so authoritatively from your own work. And it's not only with one pathogen or one disease, it's in the whole spectrum of infectious disease, including tuberculosis and acute infections. So I really do appreciate, and also the work you have done on inborn errors of immunity, which we are also trying to do something over here. And that really, I must congratulate you and your team for, most importantly, giving us a stimulus, not only to treat patients, to have a keen sense of observation and to think out of the box, and also to make sure that everything is documented and published. Fantastic work, and really congratulate you and your team. Thank you. Thank you so much.
Thank you very much. Thank you. Thank you very much.
CK sir, shall we conclude? If there are no more questions.
Yes, please.
Sir, on behalf of IAP Kozhikode and IAP Kerala, we would like to express our gratitude to Balasubramanian sir for that wonderful presentation on pediatric infectious disease, from the good experience he has accumulated over the past so many years, and the good research publications and the latest studies on MISC, which is the way forward for youngsters also. So thank you, sir, for this wonderful presentation. Thank you, sir. Also, I would like to express thanks to CK Shashidharan sir, senior pediatrician, and for moderating this session so wonderfully, and all our senior members, and Dr. Mohandas sir, Dr. Krishna Kumar sir, Geeta ma'am, Ajit sir, Parvati ma'am, for joining this session, and they're giving valuable inputs also. Thank you, everyone. Thank you, sir.
Thank you.
Good night, sir.
Good night, sir. Good night, sir. Good night, sir.
Thank you, sir. Thank you, sir.
Good night.
Thank you.